It's Dr. Swati, lecturer, Department of Oral Medicine and Radiology from SRM Dental College, Ramapuram, presenting the e-content on anatomical landmarks in intraoral periapical radiographs. So why do we need to know anatomical landmarks at the first place? The radiographic recognition of a disease requires a sound knowledge of the radiographic appearance of normal structures. A proper diagnosis mandates an appreciation of the wide range of variation in the appearance of normal anatomical structures. So basically, to know what is abnormal, first we have to know what is normal. Teeth are composed primarily of dentine with an enamel cap over the coronal portion and a thin layer of cementum over the root surface. The enamel cap appears radio-opaque. Dentine is 75% mineralized, so the radiographic appearance is similar to bone. Cementum is usually not evident in a radiograph because the radiographic contrast between dentine and cementum is similar. Pulp has soft tissue and it appears radiolucent. Coming to the supporting structures, the first structure is the lamina dura, otherwise called as alveolar bone proper. A radiograph of a sound dental teeth in a normal dental arch demonstrates that the tooth sockets are bounded by a thin radiopaque layer of dense bone, which is this lamina dura. This layer is continuous with the shadow of the cortical bone at the alveolar crest. The thickness and density of the lamina dura on the radiograph vary with the amount of occlusal stress to which the tooth is subjected. The lamina dura is wider and more dense around the roots of teeth in heavy occlusion and thinner and less dense around teeth not subjected to the occlusal function. The second supporting structure is the alveolar crest. The gingival margin of the alveolar process that extends between the teeth is apparent on radiographs as a radio-opaque line, which is the alveolar crest. The level of this bony crest is considered normal when it is not more than 1.5 mm from the cemento-enamel junction of the adjacent teeth. The third supporting structure is the periodontal ligament space. The periodontal ligament space is primarily composed of collagen, so it appears as a radiolucent space between the tooth root and the lamina dura. This space begins at the alveolar crest, extends around the portions of the tooth roots within the alveolus and returns to the alveolar crest on the opposite side of the tooth. The fourth supporting structure is the cancellous bone, also called as the trabecular bone or spongiosa, that lies between the cortical plates in both the jaws. It is composed of radio-opaque plates and rods, which is the trabeculae, surrounding many small radiolucent pockets of marrow. The radiographic pattern of the trabeculae comes from two anatomical structures. The first is the cancellous bone itself. The second is the endosteal surface of the outer cortical bone, where the cancellous bone fuses with the cortical bone. Now let us deal with the anatomical landmarks that is seen in the maxilla. The first landmark is the intermaxillary suture, which is otherwise called as the median suture, and it appears on the intraoral periapical radiographs as a thin radiolucent line in the midline between the two portions of the premaxilla. It extends from the alveolar crest between the central incisors superiorly through the anterior nasal spine and continues posteriorly between the maxillary palatine processes to the posterior aspect of the hard palate. The second structure is the anterior nasal spine. The anterior nasal spine is most frequently demonstrated on periapical radiographs of the maxillary central incisors. It is located in the midline and lies approximately 1.5 to 2 cm above the alveolar crest, usually at or just below the junction of the inferior end of the nasal septum and the inferior outline of the nasal aperture. It is radio-opaque because of its bony composition and is usually V-shaped. The third structure is the nasal aperture, and it has got an anterior floor of the nasal aperture as the yellow lines points out to. And we have the nasal aperture or the nasal fossa and the nasal septum. So the nasal aperture is otherwise called as the nasal fossa. It is an air-filled cavity. It lies above the oral cavity. Its radiolucent image may be apparent on intraoral radiographs of the maxillary teeth, especially in the central incisor projection. On the periapical radiographs of the incisors, the inferior border of the fossa appears as a radiopaque line extending bilaterally away from the base of the anterior nasal spine. Above this line is the radial space of the inferior portion of the cavity. If the radiograph was made with the X-ray beam directed in the sagittal plane, The relatively radiopaque nasal septum is seen arising in the midline from the anterior nasal spine. The nasal cavity contains the opaque shadows of the inferior concha, extending from the right and left lateral walls of varying distances towards the septum. So this septum is marked with the yellow arrow. It's a thick bone that is seen dividing the nasal fossa into two compartments. The next landmark is the Incisophosar, which is otherwise called as the Nasopalatine Foramen or Anterior Palatine Foramen in the maxilla, is the oral terminus of the Nasopalatine Canal. This canal originates in the anterior floor of the nasal fossa. The Incisophosar transmits the nasopalatine vessels and nerves and lies in the midline of the palate behind the central incisors, approximately the junction of the median palatine and the incisive sutures. It is seen as an ovoid radiolucency between the two maxillary central incisors. The next landmark is the superior foramina of the nasopalatine canal. The nasopalatine canal originates at two foramina in the floor of the nasal cavity. The openings are on each side of the nasal septum close to the anteroinferior border of the nasal cavity, and each canal passes downward anteriorly and medially to unite with the canal from the other side in a common opening, which is the incisive or the nasopalatine foramen. The superior foramina of the canal occasionally appear in projections of the maxillary incisors, especially when an exaggerated vertical angle is used. They are usually round or oval, although they make various outlines depending on the angle of projection. The next landmark is the lateral fossa, otherwise called as the Incisophosar, which is a gentle depression in the maxilla near the apex of the lateral incisor. It may appear diffusely radiolucent on periapical projections of this region. Then we have the soft tissue outline of the tip of the nose that is frequently seen in projections of the maxillary central and the lateral incisors superimposed over the roots of the teeth. The image of the nose has a uniform or slightly opaque appearance with a sharp border. Occasionally, the radiolucent nares can be identified, especially when a steep vertical angle is used. Next we have is the Nasolacrimal Canal. The nasal and the maxillary bones form the Nasolacrimal Canal. It runs from the medial aspect of the anteroinferior border of the orbit inferiorly to drain under the inferior concha into the nasal cavity. Occasionally, it can be visualized on periapical radiographs in the region above the apex of the canine, especially when a steep vertical angle is used. However, nasolacrimal canals are routinely seen on a maxillary occlusal projection, as you can see the yellow outline marking to the nasolacrimal canal. The next important landmark is the maxillary sinus, which is similar to the other paranasal sinuses, is an air-filled containing cavity lined with a mucous membrane. It develops by the invagination of the mucous membrane from the nasal cavity. It is the largest of the paranasal sinuses. It normally occupies virtually the entire body of the maxilla. The sinus is considered as a three-sided pyramid with its base, the medial wall adjacent to the nasal cavity, and its apex extending laterally into the zygomatic process of the maxilla. Its three sides are the superior wall forming the floor of the orbit, the anterior wall extending above the premolars, and the posterior wall bulging above the molar teeth and the maxillary tuberosity. Next, we have this landmark, which is the inverted Y line of Ennis. It is seen as a radio-opaque line that is formed by the intersection of the floor of the nasal cavity and the anterior wall of the maxillary sinus. The next landmark is the zygomatic process of the maxilla. The zygomatic process of the maxilla is an extension of the lateral maxillary surface that arises in the region of the apices of the first and second molars, and it articulates with the maxillary process of the zygoma. On periapical radiographs, this zygomatic process appears as a U-shaped radio-opaque line with its open and directed superiorly. The enclosed rounded end is projected in the apical region of the first and the second molars. The size, width, and definition of the zygomatic process are variable, and its image may be large depending on the angle in which the beam was projected. Next, we have the Nasolabial Fold, which is seen as an oblique line demarcating a region that appears to be covered by a wheel of slight radio opacity, frequently traverses periapical radiographs of the premolar region. The line of contrast is sharp, and the area of the increased radio opacity is posterior to the line. The line is a nasolabial fold, and the opaque wheel is a thick cheek tissue superimposed on the teeth and the alveolar process. Next, we have the pterygoid plates. The medial and lateral pterygoid plates lie immediately posterior to the tuberosity of the maxilla. The image of these two plates is extremely variable and they do not appear at all in many intraoral radiographs of the third molar region. When they are apparent, they almost cast a single radiopaque homogeneous shadow without any evidence of trabeculation. Extending inferiorly from the medial pterygoid plate is the Hameler process, which on close inspection can reveal the trabeculae. Coming to anatomical landmarks in the mandible, the first we have here is the symphysis. Radiographs of the region of the mandibular symphysis in infants demonstrate a radiolucent line through the midline of the jaw between the images forming deciduous central incisors. The suture closes at the first year of life, after which no longer it is radiographically apparent. So this is an infant radiograph showing the symphyseal suture. The next landmark is the lingual foramen. So this is a foramen on the lingual surface of the midline of the mandible in the region of the genial tubercles, the lingual foramen. There are often two or even more such foramina. The superior foramen contains the neurovascular bundle from the lingual arteries and nerve, whereas the inferior foramen is supplied from the sublingual or the submental arteries and from the mylohyoid nerve. The lingual foramen is typically seen as a single round radiolucent canal with a well-defined radiopaque border lying in the midline below the level of the apex of the mandibular central incisors. The next landmark is the genial tubercles, which is also called as the mental spine. It is located on the lingual surface of the mandible, slightly above the inferior border, and it's in the midline. They are bony protuberances, more or less spine shape, often divided into the right and left prominence and a superior and inferior prominence. They attach the genioglossus muscles at the superior tubercles and the geniohyoid muscles at the inferior tubercles to the mandible. They are well visualized on mandibular occlusal radiographs as one or more small projections. The appearance of the periapical radiographs of the mandibular incisor region is variable. They appear as a radio-opaque mass, often like 3 to 4 millimeters in diameter, in the midline below this incisor roots. The next landmark is the mental ridge. On the intraoral periapical radiographs of the mandibular central incisors, the mental ridge or protuberance may occasionally be seen as two radio-opaque lines sweeping bilaterally forward and upward towards the midline. They are often of variable width and density and may be found to extend from low in the premolar area on each side up to the midline, where they lie just inferior to or superimposed on the mandibular incisor tooth roots. The image of the mental ridge is most prominent when the beam is directed parallel with the surface of the mental tubercle. The next landmark is the mental fossa. The mental fossa is a depression on the labial aspect of the mandible, extending laterally from the midline and above the mental ridge. Because of the resulting thinness of the jawbone in this region, the image of the depression may be similar to the submandibular fossa. The next important landmark in the mandible is the mental foramen, which is usually the anterior limit of the inferior dental canal that is apparent on periapical radiographs. The foramen image is quite variable and may be identified only about half of the time because the opening of the mental canal is directed superiorly and posteriorly. As a result, the usual view of the premolars is not projected through the long axis of the canal opening. The next landmark is the mandibular canal. The radiographic image of the mandibular canal is seen as a dark linear shadow with thin radiopaque superior and inferior borders cast by the lamella of bone that bounds the canal. Sometimes borders are seen only partially or not at all, and the width of the canal shows some interpatient variability, but it's usually constant anterior to the third molar region. The canal scores may be apparent between the mandibular foramen and the mental foramen. Only rarely the image of its anterior continuation towards the midline is discernible on the radiograph. Next, we have the nutrient canals. Nutrient canals carry a neurovascular bundle and appear as a radiolucent line of fairly uniform width. They are most often seen on the mandibular periapical radiographs running vertically from the inferior dental canal directly to the apex of the tooth or into the interdental space between the mandibular incisors. They are visible in about 5 to 40% of the patients, are most frequently seen in the black patients, male patients, and slightly older patients with advanced age or high blood pressure, diabetes mellitus, or advanced periodontal disease. Next, we have is the mylohyoid ridge, which is otherwise called as the internal oblique ridge. This is a slightly irregular crest of bone on the lingual surface of the mandibular body. Its anterior margin lies about 10 millimeters inferior to the alveolar ridge lingual to the second premolar and extends posteriorly to the area of the third molar above 5 mm below the alveolar crest. This ridge serves as an attachment for the mylohyoid muscle. Next we have is a submandibular gland fossa. On the lingual surface of the mandibular body, immediately below the mylohyoid ridge in the molar region, there is a depression of bone. This concavity accommodates the submandibular gland and often appears as a radiolucent area with sparse trabecular pattern characteristic of this region. This trabecular pattern is even less defined on the radiographs of the area because it's superimposed on the relatively reduced mass of the concavity. The radiographic image of the fossa is sharply limited superiorly by the mylohyoid ridge and inferiorly by the lower border of the mandible, but is poorly defined anteriorly in the premolar region and posteriorly at about the ascending ramus. The next landmark is the external oblique ridge. The external oblique ridge is a continuation of the anterior border of the mandibular ramus. It follows an antero-inferior course lateral to the alveolar process. It is relatively prominent in the upper part and considerably on the outer surface of the mandible in the region of the third molar. This bony elevation gradually flattens and usually disappears at about where the alveolar process and mandible join below the first molar. The ridge is a line of attachment to the buccinator muscle. Next we have is the inferior border of the mandible. It is seen on the periapical radiographs occasionally and seen as a characteristically dense, broad, radio-opaque band of bone. So this is the only landmark of the mandible seen in a maxillary IOPA, which is the coronoid process. The image of the coronoid process of the mandible is frequently evident as a triangular shaped radio opacity with its apex directed superiorly and anteriorly superimposed on the region of the third molar near the maxillary molar region. In some cases, it may appear as forward as a second molar and projected above or below these molars depending on the position of the jaw and projection of the X-ray beam. So this is just a summary of the outline of the anatomical landmarks in intraoral periapical radiographs. Thank you.